स्क्रीन आ रहा है?
Yes.
Welcome
Very.
everyone. Hello everyone. Welcome to Neuraxis
Yes.
2020. We are here starting with the junior category paper presentation today. And let me welcome our coordinator today, Dr. Chitransi and Dr. Vaisali. And today's moderator, Dr. Sagun Agrawal. Join hand with me to welcome judges today, Dr. Pawan Saini and Dr. Snehal Patel, ma'am. Welcome you both, judges, today. You can start your presentation for this paper presentation now, sir.
Good evening, everybody. On behalf of Neuraxis 2020 team, we welcome all our judges, Dr. Pawan Saini sir, Dr. Snehal Patel, and coordinator for the paper presentation. It's my privilege. We are conducting the 6th e-Neuraxis, and we have finalized the 5 papers on the YouTube presentation. The sequence is like this: 5 students would be presenting. I would like to call first presentation for the Miss Tanya.
Yes, sir. Am I audible to everyone?
Yes, Tanya.
So can you please start my PPT?
Yes,
Thank you. Good evening, everyone. I'm Tanya Goel, pursuing MPT Neurological Physiotherapy from MMIPR, Mullana. I want to prepare a present paper on topic, effectiveness of immersive virtual reality training to improve balance control among patients with paraplegia. Two-group pre-test, post-test, randomized control trial. Next. Okay, the background of this study, sitting balance plays a rudimentary role for many of the functional activities like eating, dressing, etc. It established that patient with spinal cord injury lacks sitting control in them. And VR technology is a promising intervention for improving balance among these patients. My next, please. So my aim of this study is to devise a protocol which shall be helpful to improvement of static and dynamic sitting balance in patients with spinal cord injury. So the need of this study came out to recognize a better rehabilitation protocol through establishing the effectiveness of virtual reality to improve dynamic and static sitting balance. Next, please. Methodology section. The study design is a participant-blinded, two-group pre-test, post-test, randomized clinical trial. Ethical clearance has been taken from Ethical Research Committee of Tertiary Care Teaching Hospital. The clinical trial registry India, it has been registered in Clinical Trial Registry India prospectively on 19th March, and your universal trial number is obtained. Next. Study location. The location of the study, it will be conducted in Neurological Department of MMIPR, Mullana, Ambala, Haryana. Study setting will be the Tertiary Care Hospital of Mullana. Sample size came out to be 24 participants, which will be taken from the same hospital. And the sample size was calculated using the comparison of two means formula. Next, please. The eligibility criteria for the patients to be screened. Patient between age group 18 to 60 will be recruited. Both males and females will be included. Patient with American Spinal Injury score BCD having the duration of less than 6 months of injury will be included. And the patient should have at least 90 degrees of shoulder flexion. The participants with any of the metal implant, any visual disorder, or upper extremity deformity, neuromuscular disorder, and autonomic dyslexia will be excluded from the study. Next, please. Okay. The procedure of the study. The patient, according to eligibility criteria, will be screened. The procedure will be explained. The intervention we are giving will be explained to the patient in detail, and written informed consent will be taken from them in any language they prefer. Demographic profile of the participant will be evaluated in the assessment form, like age, BMI, and the history of present illness will be taken here. Participant will be randomized into two groups using block randomization with the 4 into 6 matrix coming out to be 24 sample size. And group A will be VR training with the help of head mounted display, which is immersive type of virtual reality training. And group B will be function electrical stimulation in simultaneous and alternative mode. Post-treatment outcome measures will be evaluated, data will be recorded and analyzed, data management will be there, and confidentiality will be kept. The results shall be presented in form of table, figures, and written communication, and will be discussed under discussion and conclusion. Next, please. Hello.
Yes, Tanya.
Sir, it's not. Yes, thank you, sir. The outcome measures of my study is modified functional reach test, function in sitting test, and spinal cord independence measure. It will be taken prior to the intervention, in between, and after the intervention. Next, please. Okay. My first intervention, as we discussed, is virtual reality training. It will be given for 45
Sir, not able to
minutes
hear.
each. The games are head-mounted display I'm using is Oculus using the virtual. Am I audible?
Yeah, Tanya, I speak
Now
because
audible.
your voice was not coming. Now it's coming.
Okay, okay. I'm using Oculus Grand Virtual Reality VR headset. The virtual environment I'll be exposing the patient to is roller coaster VR, VR tunnel race, and in-mind VR. This will provide patient a challenging environment and uh, rehabilitation for trunk muscles. Okay, next, please. Next. Okay, the second intervention is functional electrical stimulation. It will also be applied for 45 minutes.
Tanya, 1 minute more. Last 1 minute.
Okay, okay, sir. Okay, sir. It will be applied to rectus spinae and rectus abdominis muscles, simultaneous and alternate mode. The data analysis, normal distribution. If there is normal distribution, the parametric test will be used, and not normal distribution, non-parametric test will be used. Next. So I will conclude by saying that immersive virtual reality is a cost comfortable and adjunctive to conventional therapy, and gaining patient confidence treatment. So it will be a very helpful treatment for patient with SCI to develop a better sitting balance and help them with activities of daily living. Limitations are that we are not provided with the better instruments like Oculus Rift or HTC Vive. And the most important limitation in today's scenario is COVID-19, which is going on, and the patients are less available. Okay, next. Next. Thank you so much, everyone.
Thank you, Tanya. Now I would request our judges, Dr. Pawan Sani sir and Dr. Snell, you can ask questions, sir.
Yeah, Tanya, can you tell me why you have taken the age group from 18 to 16, and this is a very big difference of this age group? Can you hear me? Hello?
Tanya, give the answer. Miss Tanya? Tanya, sir, Dr. Pawan, sir, is asking question.
Hello.
Yes.
Hello,
Tanya,
Tanya,
give
can you
your
hear me?
answer.
Yes, hello.
Can I speak again, or already you have heard?
I think she hasn't understood. You can repeat, sir.
Okay.
Am I audible?
Okay,
Hello.
sir. Again, I will repeat the question. Can you tell me why you have taken the age group from 18 to 60? Because this is a very big difference. Because one patient with a 18-year age and one with a 60 years of age, they will be performed differently.
I think she's left because of the internet, sir. So we can proceed with another next
Yeah,
one.
we can go for the another participants. The second participants. Kindly the slide, please, sir. The second participant is Apurva Srivastav from Maharishi Markandeya Institute of Physiotherapy Sciences.
Yes.
Apurva, please.
Okay. Thank you, sir. Thank you, Agarwal, sir. Good afternoon to one and all. Today, I, Apurva Srivastava from MMIPR, Maharishi
Am I
Markandeshwar
audible?
Institute of Therapy and Rehabilitation, is here to present my study protocol, which is Effectiveness of Rehabilitation Protocol for Early Management of Craniotomy Patients to Improve Functional Outcomes in Intensive Care Units. So, next slide.
Hello.
Yeah.
So,
Tanya, we would listen
Tanya, we will have
lately.
your question later on.
okay, thank you, sir. Thank you, sir. Okay.
I'll be conversing my material through introduction, materials and methods, interventions, outcomes, statistical analysis, and discussion. Next slide, sir. So, introduction. As we all know, craniotomy is a widespread procedure. It has numerous complications. It has numerous things to deal with. Till date, there is no rehabilitation protocol which is proven to be effective, evidence-based in neurosurgical patients, especially with craniotomy procedures. Next slide, sir. These are some of the complications which I have summarized here. Prolonged ICU stay and financial burden have proven to be the most important one. Delaying weaning off, electrolysis, delirium, coma, respiratory failure, poor quality of life post their surgical procedure, sputum accumulation, mortality, muscle wasting, ventilator-acquired pneumonia, polyneuropathy, myopathy. These all are the complications which we deal symptomatically in a neurosurgical intensive care unit. Next slide, sir. Objective. My main objective of the protocol is to establish a neuro rehabilitation protocol, improving their functional outcome in a very short duration of period to reduce their ICU length of stay. Next slide, sir. Material and methods. Study design, single group, pre-test, post-test, double-blinded feasibility trial. Ethical approval is obtained from Maharishi Markandeshwar Institute of Medical Sciences and Research. CTRI registered, universal trial number is given, and my copyright number is also given. This is my copyright and the CTRI. Population, I have taken inclusion criteria for patients between 18 to 55 years of age. They will be mechanically ventilated post-surgical intervention. Craniotomies would be opted due to cerebral aneurysm, stereotactic aspiration, extended bifrontal craniotomy, minimal invasive supraorbital craniotomy, removal of blood clots from blood vessels, drainage of brain abscess, repairing of skull fractures, and subarachnoid hemorrhage. The patients which I'll not be recruiting would be patients with nosocomial infections just after the post-surgical period, just in the post-surgical period, sorry. Unstable patients with unstable vital parameters, because it is proven that patients post-surgery undergo hypertension. So patients with unstable parameters from 6-hour duration would be excluded. Next slide, sir. Study setting neurosurgical ICU in super specialty hospital, blinding, double-blinded, outcome assessor, and participant will be blinded. Participants' family will be contacted for informed consent, and the outcome will be assessed from a experienced person which has been working for several years in neurosurgical ICUs as physiotherapist. Sample size as per the needs of sorry, sir, the slide back. Sample size as per the needs of any pilot study. I'll be taking 12 sample size. So next slide. Patient recruitment, WHO format, informed consent will be obtained from patient's family before the recruitment of the patients. Next slide, sir. Procedure, the whole procedure will be assessment of eligibility criteria. After that, attainment of informed consent from patient's family, baseline characteristics, age, demographic data, and everything will be collected. Assessment of outcome measure primarily on the very first day. Delivery of rehabilitation protocol which will be a 15 days long protocol, and reassessment of outcome measures at the end of 15-day duration. Next slide, sir. Outcomes, my primary outcome will be early functional ability scale. This scale has been proven to be effective in unconscious and semi-conscious patients in a study of 2015. Secondary outcomes which we'll see are Glasgow Coma Scale, Montreal Cognitive Assessment Scale, Coma Recovery Scale, Modified Ashworth Scale, Medical Research Council Scale, Sensory Modality Assessment and Rehabilitation Technique, and chest X-rays. Next slide, sir. Intervention. This is my protocol which I have made and I have copyrighted it. This is a 15 session protocol, 15 days per one session per day protocol, and it is covered under 5 main domains, which is regain of consciousness, chest physiotherapy, sensory re-education, motor relearning, and limb physiotherapy. It includes vast variations of interventions from TDCS, music therapy, and the conventional therapies being readily used in ICUs till date. Next.
Apurva, only 1 minute left.
Yes, sir. Next slide. Statistical analysis. If normality will be assessed. If it follows normal distribution, paired t-test will be applied. If not normal, then Wilcoxon sign rank test. Post hoc analysis will be done. So next slide. So next slide, please. Of ICU patients will be able to summarize the whole financial burden and reduce it. The strength of my protocol will be that it is a first overall rehabilitation protocol whose feasibility will be evaluated. And limitation is, as the pandemic is going on and availability of patients will be a major concern. I rest my study protocol here. Next slide, sir. These are the references. Thank you.
Now the forum is open for the discussion. I would request my panelists to ask questions.
Hello?
Yes, ma'am.
Yeah, Apurva, you said in exclusion criteria, the amputated patients you have not taken. Why? It is anything specific?
Ma'am, with amputed patients, it is necessary. It will be necessary for me to take help from a orthopedic physiotherapist, because the protocol is diverse, is very vast for amputated persons, and overall, due to amputation, it is seen that motor relearning becomes much more difficult and time taken. Since it is a time-bound protocol, so I have excluded the amputated patients.
Okay. Okay. Thank you. Good. So you can ask Pavan, sir.
Yeah. Again, I am asking the same question. Why you have taken the age group like very approximately 20 to 60 years?
Sir,
Today,
I have taken I agree, this is a very vast age group, but I have taken this age group because the study setting where I am taking patients from, the range of craniotomy patients is very vast. It is not following a normal distribution that only this group of patients are eligible for craniotomy. There are numerous reasons and numerous patients which undergo craniotomy, and because of that, I have to keep the age bar quite large. And if it is accessible in the pandemic also, that this age group could be easily obtained.
yeah,
Patient.
that is a valid point. Only the COVID. Otherwise, the age group is very vast. Difference of age group is very vast.
Sir,
Yeah, the
actually the occurrence of subarachnoid hemorrhage, which I'm taking as an inclusion criteria, it has nothing to do with the age group bars. That is why
yeah,
I had to take a
that
large.
that is one of the inclusion criteria. That is only one of the inclusion criteria.
Yes, sir. Yes, sir.
Okay, thank you.
Any further questions, sir? Can you proceed for the further presentation?
Yes, sir. Yes.
Okay.
Thank you, sir.
Thank you, Apurva. Next presentation, please, sir. Now I would invite Shadad. Please, Shadad.
Shahad. Hello.
Yeah.
Yes, hello everyone. My name is Shahada Zahrani. I'm a physical therapy master student from King Abdulaziz University. From
Your video is not open. Your video is not coming.
Yeah, I apologize for that. I have technical issues.
Okay, go on.
Okay, so I'm proud to present my paper for today is the risk factor of fall in adult cancer survivors. Next slide, please. So as we all know, falls are considered a major health problem in the whole world, and it's considered to be the second leading cause of fatal injuries in the world. And for cancer survivors, the risk of falling is proving to be high. And as the incidence of cancer is continuously increasing in the future, cancer patients will be needing more focused and intense care from all healthcare professionals, including physical therapists. Next slide, please. Fall prevention is one of the many goals therapists are focused on when working on the rehabilitation of cancer survivors. So in order to prevent the incidents, we need to know the exact characteristic of the patient that are at high risk of fall, so that clinician can appropriately prescribe the appropriate therapeutic intervention for those in need. Next slide, please. So our study is a case control study for a patient over the 18 years of age and who has previously diagnosed with cancer in the last 10 years and were previously treated with chemotherapy. And they were excluded if they had any neurological or musculoskeletal issues, also if they had an impaired cognition or any psychiatric illnesses that could interfere with the assessment of these patients and could affect their balance. Also, if they currently were on active chemotherapy, as we're trying to avoid the fatigue to affect our results. Next slide, please. 9 subjects were diagnosed with cancer were obtained from the oncology outpatient clinic in our university hospital, and an ethical approval was obtained. And after signing the consent form, assessment was done using the following outcome measures. The outcome measures, we've mainly focused on the variables that physical therapists are mainly focused on assessing and are able to modify. And if these outcome measures were proven to be related to falls, then the physical therapist can help to prevent the incidence. So, for example, for balance, we use the Fullerton Advanced Balance Scale. For muscle strength, we use the handheld digital dynamometer. For the chemotherapy-induced peripheral neuropathy, we use the total neuropathy score. For gait speed, we use simple timed up big go test. And for the fear of fall, we use the fall efficacy scale. Next slide, please. And of course, regarding to fall, we asked our patient if they had any incident of fall in the last 12 months, and the number was recorded. And of course, the demographic characteristic was recorded out of the patient's medical record. Next, please. Our results. Out of the 9 patients that we have, 3 of them were fallers. And after dividing our samples into dividing our patients into fallers and non-fallers, we did a binary logistic regression to analyze the factors associated with falls, and the results were as follows. Next, please. And regarding of balance, assessed with the Fullerton Advanced Balance Scale, we can see that the odds ratio is actually quite significantly high, as for every 1 point of Fullerton decrease in the Fullerton scale, there's a 26.64% increase of the chance of fall in cancer patients. In comparison, we can see to the TUG or the gait speed, it's only 1 point. There's also a positive association, but it's considered to be 1.5, not as high as for the balance. We can see also for the FAB and TUG that the p-values are unfortunately also not significant. Next. For here, we can see the assessment for the fear of fall and the neuropathy that the patient, the neuropathy symptoms. We can see the odds ratio is 1.04 and 1.09, not also as high as for the balance, but it's considered to be a positive relationship. And also for both of them, the p-values is not quite significant. Next, please. For knee flexion and knee extension is slightly better than the previous results. For knee flexion, especially, we have 1.47, and knee extension, we have 1.4. Also, the p-values are not quite significant. Next, please. For the ankle plantar flexion and ankle dorsiflexion, we can see that the ankle plantar flexion is actually higher odds ratio than the knee flexion or the previous result, except for the balance. But also we can see that the p-values are not significant. Next. So in regarding of balance dysfunction is significant fall predictor, but some of the writers contributed that to the vestibular dysfunction that cancer patient had due to the chemotherapy treatment. And another side effect for the treatment is the chemotherapy-induced peripheral neuropathy. Some studies found that these patients have higher fall incidence at almost 3 times higher than those without peripheral neuropathy. But we couldn't find that significant result in our study, probably due to the limited sample size. Another point is regarding the abnormal gait speed. Abnormal gait speed is common to be predictor of fall, but in this study was done in 2015. They saw that even when gait was slow in cancer patient, it was not associated with fall, even when they assessed with the 4-meter walk test in comparison to our TUG test. Next slide, please. Regarding the fear of fall, it's a common fall predictor for the older population, but for cancer, it was also associated with increased risk of fall. But the same conclusion that we reach, there's 2 studies that didn't also found a significant association with falls, whether they tested with the fall efficacy scale or the activity-specific balanced confidence scale. And regarding cancer patient with history of fall found to be significantly regarding the lower limb strength.
Only 1 minute left.
Okay.
Only 1 minute left.
Okay. According to a review was done for 29 studies, lower limb strength is less associated with falls than balance in gait speed, which should also mention that our study is the only one to objectively assess the muscle power using digital hand dynamometer. Next, please. Next, please. Our obvious limitation of a study was the small sample size. As we understand, there's with the whole virus conditions happening in the world, in the time limitation, we were only able to obtain the 9 sample size that we have, but we're currently working on a larger sample. And also the lack of diversity regarding the gender in cancer tab in our sample is another issue, as we mentioned that we only have 9, 8 of them were female and 7 of them had breast cancer. Next. So we can conclude that 33% of our sample were fallers. Balance, gait speed, peripheral neuropathy, fear of fall, and muscle power were found to be associated with falls. And especially the Fullerton Advanced Scale has shown to a significant likelihood of fall at almost 27 times higher chance of fall for every 1 point decrease in the total score. Small number of participants was a main limitation, and future research direction should emphasize on the effect of rehabilitation program, focusing on these aspects to decrease or prevent fall risk in cancer survivors. That's it. Thank you so much. And I would like to thank my supervisor, Dr. Fayaz Khan, for his assistance, and thank you for listening.
Thank you. Now I would request all the panelists, you can ask questions, sir and ma'am.
Yeah, sir. Can you tell me, you have taken the sample size of 7 female patients of breast cancer and another was pancreatic cancer. So why you have not taken the only breast cancer patients?
Unfortunately,
yeah. Already you have mentioned in the limitations, but it will be better if you take the same type of patient. And already you have tell us about the limitations. Can you say something for that?
On why we only had breast cancer for the majority, you mean?
Yeah.
Can you repeat the question, please?
Yeah, the question is, you have taken 7 patients of breast cancer.
Yes.
Okay. And one was pancreatic cancer. So I just want to ask why you have not taken all the breast cancer patients so that the study will be better.
If I had the chance, I would, but unfortunately, for the limited time, these
so
I took all.
The pancreatic cancer patient.
Excuse me, what?
It will be better if you have eliminated the pancreatic cancer patient.
Yes, of course. I wanted a larger or more diverse group of cancer patients, not only breast cancer, but that's due to the time limitation I had. And I included all the patients that I could have, and by coincidence, it turns out to be all of them are breast cancer, and all of them are, or the majority of them are females.
Yeah. Okay.
Sir, I had a question like how did you measure lower extremity strength, and what was the importance of using handheld dynamometry for balance?
Yes, for balance, you mean? Okay. As we know, the chemotherapy, especially neurotoxic types of chemotherapy, has an effect on the extremities. It can affect patients' balance. Some studies stated that. So measuring the muscle power, and especially the lower limbs or the hands even, but since we were considered imbalanced, so we were more interested in the lower limb muscle power. That's why.
How did you measure that?
Using the digital handheld dynamometer.
The lower
I mean handheld by the patient, by the therapist, I mean, but it was able to measure it in the knee by placing it on the shaft of the legs.
Okay. And which all muscles were included?
For extension and flexion, like you mean?
Yes. How many group of muscles did you use?
4 group of muscles: the knee flexors and extensors, and the ankle plantar flexors and dorsiflexors.
Okay, it wasn't mentioned anywhere in your presentation. Thank you.
Okay, thank you.
Dr. Snehal, would you like to ask anything?
No, sir. Go ahead.
Anybody else? Forum is open for discussion. Anybody from the committee?
Sir, if you allow me, I have one more small question. Like, was vision assessed of the patient?
Excuse me, come again?
Did you check the vision of every patient?
The vision, no.
No, because that could have an impact on balance and fall.
Yes, of course. Yeah. We wanted to assess the balance can be assessed in whether static balance or dynamic balance, and each of them has. And we also wanted to do objective assessment, but that's what we could do for this study.
Okay, thank you.
Thank you.
Now I would request for the next presentation. we would like to invite for the factors affecting falls with multiple sclerosis. I would request to invite Mr. Adil M. Javed.
Yes, this is me.
Okay, now you can start your presentation, Adil.
Good evening, everyone. This is Adil Mahmoud Jawad. I'm a physical therapist at King Fahd General Hospital in Jeddah and master student at KAU University in Jeddah. Today, I'm going to present the factors affecting falls in people with multiple sclerosis. Next, please. As you can see here, the prevalence of MS has been significantly increased globally in the last decade. In the Arabian Gulf region, the prevalence has been doubled in the 90s of 20th century. Approximately, the increasing of MS prevalence was 5.5 annually. Next, please. Next, please. A series of problems are facing multiple sclerosis individuals, which may affect their physical activity level, psychological aspect, quality of life, and risk of fall. More than 50% of falls occur in 3 to 6 months period after they diagnosed with multiple sclerosis. Next, please. According to the World Health Organization, falls are considered as the major health problem, and they are the second prime cause of fatal injuries in the world. Next, please. Therefore, there is an urgent need to investigate the factors affecting falls in multiple sclerosis. This study aimed to assess the factors that affecting falls in multiple sclerosis population and mapping out the most significant variables. Next, please. 13 participants were recruited in this case control study with including criteria: conferred MS diagnosis by a neurologist, expanded disability status scale less than or equal 6, adequate cognitive function to participate in the assessment, ability to walk with or without a walking aid, and no exacerbation of symptoms 30 days prior to completing testing, and age above 18 years. Next, please. In this study, I examined 4 variables: balance by Fullerton Advanced Balance Assessment Scale, gait, speed through time up and go test, fear of falling by Falls Efficacy Scale International, knee and ankle muscle strength through handheld dynamometer. Next, please. We obtained at the baseline data in the first administration. Each participant received a phone call to determine the number of falls, and finally, a simple binary logistic regression was performed to detect the predicted direction of falls. Next, please. In my result, during the last 3 months of follow-up stage, only 23% of participants had fallen at least once. Balance was the most significant variable among the tested variables. Time up and go test showed a perfect area under care value compared to the tested variables. There were no significant values on the rest of tested variables, and the probability of risk fall will be increased 1.5 times per every second delay in time upon go test. Next. In this slide, we can see that balance was the most significant variable among the other tested variables with odd ratio 73.13, p-value 0.03, and area under curve 0.7. Next, please. In the time up and go, odds ratio was 1.53, p-value 0.1, and the area under curve was high as 0.9. Next, please. There was no significant association between fear of falling and falls in our findings ratio. Yeah, and we can see that now. Next, please. Yeah. Also, there was no significant association between either knee and muscle in our findings. Next, please. Yeah. Next. Next, please. Yeah. Balance is a complicated function, can be achieved through multiple systems in interaction to maintain individual position. One study reported that people with multiple sclerosis who experienced falls in the last 6 months and had cerebellar region in compared to non-fallers group. Therefore, visuomotor function is playing a crucial role in maintaining balance. Hence, lesion in this area leads to balance impairment. Next, please. Recently, one study found time of Van Gogh is not significantly different between fallers and non-fallers groups, which agreed with our findings. Although they obtained poor area under curve value by 0.6, while we obtained a good area under curve by 0.9 in our study. And there's one study reported that MS individual had achieved high score of falls efficacy scale international, whether they
Adil, only
experienced
1
falls or
minute
not.
is left. Adil,
Okay.
1 minute is
Yes,
left.
sir. Okay. However, fear of falling might develop 20 to 39% in individuals who experience fall. Next, please. In my recommendation, health care provider need to emphasize the importance of balance assessment and training. Home care providers need to encourage and train to follow best practice in fall prevention, motivate people with multiple sclerosis to be committed to a lifelong physical rehabilitation regimen, and promote community awareness toward the nature and needs of multiple sclerosis population. Next, please. To conclude that balance is the highest association risk factors with falls in multiple sclerosis in comparison to similar variables that fail to display significant association to falls as fear of falling, knee and ankle muscle strength, and gait speed. This is the end of my presentation, and thank you.
Thank you. Now the forum is open for discussion. I would request panelists to ask questions.
My question is, which type of MS you are included?
Actually, we talk like every MS patient under 6 on the expanded disability scale.
Which type of MS? Like
Yeah,
progressive, progressive
no,
one or?
No, the primary MS patient. Yeah.
Okay, and how many males and females you are included? As your sample size is 13.
Yes, 13. 4 of them were male, and the rest were female.
Okay, fine.
Yeah, sorry for that. I have to say that, as we know, the prevalence in gender ratio is 2 for female and 1 for male.
Okay, okay. Thank you.
Dr. Pawan, sir?
Yeah, you have not mentioned about the vision problem, because in multiple sclerosis there is some vision problem like diplopia and nystagmus. You have not mentioned because it affects the balance.
Yeah, exactly. Actually, I didn't mention that, but in my exclusion criteria, we excluded any patient with other neurological or musculoskeletal issues that may affect balance or gait, and also impaired impairment in vision.
Okay, you have keep it in the exclusion criteria.
Yeah, exactly.
Okay.
Dr. Harpreet?
Yes, sir. Sir, you mentioned that there are 23% of the patients who had a fall.
Exactly.
Generally, what is the percentage in normal age-matched population?
Sorry, normally what?
In the age-matched non-MS population, how much is the percentage of fall in the community?
Do you mean in health population?
Yes.
Yeah, according to the previous studies, actually we didn't have a control group, but in the based on the previous studies, it was less than 12%.
Less than 12%. Okay,
Yeah.
and out of these falls, how many falls were indoors and how many were outdoors?
Yeah.
Yeah, actually, most of them were outdoors.
Most of them were outdoors.
Yeah.
Okay, and just one more question, like what is the significance of area under the curve?
What was the significant area under the curve?
In your statistics, you mentioned AUC.
Yes.
Yes. What is the significance of that?
1. Yeah, greater than 1.
Okay. Thank you.
Welcome.
I would request anything else, all the panelists. Can we move further?
Yes, sir.
Okay, thank you, sir. Next presentation, please. Uh, Ms. Kavita Koshik,
Yes, sir.
please.
Should I start, sir?
You Yes, your time starts now. Start your video also.
Am I able, sir?
Yeah, yeah, Kavita,
Good
start.
afternoon, speakers. Myself, Kavita Koshik, presenting my study protocol on topic comparing the effectiveness of transcranial direct current stimulation and cranial electrical stimulation on cognition in patient with traumatic brain injury. It is two-group pre-test, post-test randomized control trial. The background is cognitive has phenocognitive impairment is the common outcome of traumatic brain injury and has major detrimental impact on functional ability and diminishes the quality of life. And the aim of rehabilitation of cognition following the traumatic brain injury is to improve the personal ability to perform cognitive tasks, cope with affective distress, and increase self-confidence, self-efficacy, and self-awareness. Transcranial direct current stimulation and cranial electrical stimulation are non-invasive neuromodulatory devices which modulates neuronal excitability by delivering low electrical currents to brain through scalp and earlobe electrodes. Next slide, sir, please. My need of this study are cognitive impairment is the most common consequence in the individuals with traumatic brain injury, which leads to functional impairment and decrease the quality of life. Has the limited evidence-based interventions to improve cognition in individuals with traumatic brain injury. Transcranial direct current stimulation and cranial electrical stimulation proves to be promising intervention for the same, but there is a need of study to determine more potential intervention for cognitive impairment in traumatic brain injury patients. So next slide, please. My hypothesis of the study is null hypothesis stated that there may not be any significant difference between transcranial direct current stimulation and cranial electrical stimulation in improving cognition in traumatic brain injury population. An alternate hypothesis in this we hypothesize that transcranial direct current stimulation may be more potential intervention than cranial electrical stimulation or vice versa in improving cognition in traumatic brain injury population. Methods study design is parallel group, single blinded, two group, pre-test, post-test, randomized control trial, and study location will be in Maharishi Markandeshwar, deemed to be University, Bulana, Ambala. And the protocol is ethically clarified by the Institutional Ethical Committee has UTN number and CTI number are following. Next slide, sir, please. Study setting will be neurological, neurosurgery ICU and neurosurgery ward of Maharishi Markandeshwar Hospital. And sample design will be block randomization with 4 blocks and 17 rows. Sample size is 68 and was calculated by the formula mean between 2. Outcome measures are Montreal Cognitive Assessment with intra-class coefficient correlate of 0.912 and Gastron Orientation Amnesia Test with in-class coefficient correlation 0.99. Next slide, sir, please. Uh, Eligibility criteria will be inclusion criteria with age 19 to 64 and the patient within 3 months of traumatic brain injury. Both sex population were included. A MOCA score should be less than 25 and GOAT score should be less than 66. GCS score should be in between the 8 to 15. And exclusion criteria will be individuals with metal implant at the site of stimulation concomitant neurological disorder, previous history of traumatic brain injury, cyclic seizures disorder, drug and alcohol abuses, pregnant women, individuals with cardiac pacemaker, and patients with hypertension were excluded from the study. Next slide, please. Interventions. Initially, consent of the eligible patient will be collected, then baseline data, which includes age, gender, and Glasgow Coma Scale scores. Then consented subjects will receive briefing about the portable devices uses. Then the recruited subjects that were recruited were allocated randomly into two groups. Group 1 will receive transcranial direct current stimulation, while group 2 will receive cranial electrical stimulation. Both groups treatment will be performed 5 days a week and last for 4 weeks. These are my portable devices which I will use. The first one is transcranial direct current stimulation. In this, the current intensity with 2 milliampere intensity, 0.571 ampere per meter square for 20 minutes. Has electrode placements will be, the anode electrode will be placed at the left dorsolateral prefrontal cortex at the F3 according to 10-20 system electrode placement, and cathode will be placed at the right deltoid muscle. Next one is cranial electrical stimulation. In this, 0.1 milliampere intensity and 0.5 hertz frequency will be given for 60 minutes, and electrodes were placed at earlobes.
Only
Next
1 minute
slide,
left. Only 1 minute left. Conclude in 1 minute.
yes, sir. The next slide, please, sir. A statistical analysis will be baseline characteristics of eligible patient participants will be presented using descriptive stats. A normality of collected data will be established using the Kolmogorov-Smirnov test has sample size is more than 50. Based on data normality, descriptive statistic will be expressed as mean plus minus standard deviation or mean and intra-quartile range. Next slide, sir, please. The results of the comparison within the group will be, if the data is parametric, then pair t-test. If non-parametric, then Wilcoxon sign rank test. And between the group, the result will be compared by the independent t-test or the Mann-Whitney UT test. Effect size will be calculated by Cohen-T formula. The level of significance was set at 0.05 for all analyses. Statistical analysis will be performed using the SPSS statistical software version 0.16.0. Next slide, sir, please. Has discussion. The present study aimed at adding evidence that anodal transcranial direct current stimulation over the left dorsolateral prefrontal cortex and cranial electrical stimulation over earlobes might improve cognitive control. Previous literature has shown that transcranial direct current stimulation is a well-established and non-invasive technique to include targeted modulation of cortical activity associated with better working memory performance, improved cognitive control, and enhanced planning disabilities. Next slide, sir, please. Post-traumatic damage to structural connectivity of right inferior gyrus is associated with impaired network communication and executive dysfunction provide evidence that cranial electrical stimulation may result in cortical deactivation as well as altering brain connectivity in the default mode network. And in this, we use the cranial electrical stimulation. And in this, we conclude that due to the lack of the evidence of the studies of the transcranial direct current stimulation and cranial electrical stimulation in cognition, the present study will seek to compare the effect of both techniques among the traumatic brain injury individuals with cognition impairment. Next slide, sir, please.
Kavita, you are crossing the time limit. Please wind up the things.
Strength and limitations of my study are: this is cost effective, portable, it is easy to use and non-invasive devices with least side effect. And limitation of my study is patients with traumatic brain injury receiving drugs that are muscle relaxant that may affect the cognitive function. References. Thank you, sir. Thank you, teachers.
The forum is open for the discussion. I would request all the panelists, please ask questions.
Hello.
Yes.
Why you excluded the cognitively impairment individual?
Sorry, ma'am.
Why you excluded the cognitive
Yes.
impairment individual in your exclusion criteria?
And because if already there is cognitive impairment, then my results will be affected further.
Okay, fine. So you can ask.
Dr. Pawan sir,
No, sir, no.
Dr. Harpreet,
Okay, what was the size of the electrode?
So the size of the electrodes will be 2 into 3 mm.
2 into. And what medium did you use between the electrode and the skin?
So conductive paste.
What?
Firstly, saline encased with saline. Water then conductive paste will be applied on the electrodes.
Saline.
Yes, sir. Firstly, encased in saline water.
Okay. We don't use saline for TDCS because it contains ions. We use tap water generally. And what was the duration of TDCS you gave?
So 20 minutes.
20 minutes. Okay. And why did you select the DLPSP area?
So, because dorsolateral prefrontal cortex connection is by basal ganglia, thalamus, and other part of the brain which whose primary function is executive function, abstract learning, and cognitive. That's
Okay,
why I have chosen.
okay, fine. Just one last question. Like, why did you use an
Yes.
extracranial electrode? The cathode was placed on the deltoid. Why did you not use the
Yes.
electrode on the cranium?
Sir, it can be also used placed at brain cranium also to avoid the depolarization.
Why did you use it outside the cranium? Because it can affect the brain stem.
Yes, sir. Sir, because it inhibits the action.
Okay, thank you.
Thank you, sir.
thank you. Dr. Snehal and Dr. Pawan, if you give permission, you can ask the question with the Tanya because at that time she was not audible. The first presentation was of Tanya. Tanya, you are there?
Yes, sir. Am I audible right now?
Yeah, you are audible. Uh, Pawan sir, and you can ask question to Tanya.
Please brief about the presentation again for a minute only.
What
Dr.
was your
Dharam,
study about?
yeah.
To establish the effectiveness of virtual reality in patients with spinal cord injury, incomplete spinal cord injury, to regain balance control static and dynamic sitting balance.
Yeah, okay. Got it.
Yes, sir.
So can we ask question right now?
Yes, sir. She was the first presenter at that time.
Yeah. Tanya, can you tell me why you have taken this in inclusion criteria, the age group?
Yes, sir. The age group I have taken from 18 to 60, which is very vast. But as I have taken traumatic paraplegia or traumatic spinal cord injury, we see that the younger population is more into road traffic accidents and falls also due to. So that's why I have taken smaller age groups. And for the older patients, we have evidences that they fall frequently. So that's why I have taken the vast criteria. And also
So
Yes, sir.
you have not mentioned the cause of injury. Here you have not mentioned the cause of the injury, and now you are mentioning that in the young age they are getting the accidents, and in the old age like 40, 50, 60 they are getting fall. So how outcome will not be
Yes, sir.
affected?
Sir, can you please repeat your question? I'm not getting it.
Yeah, because you have taken the age group from 18 or 16 to 60, 60 years, na? Okay.
Yes, sir.
You,
Yes, sir.
and you are saying in the young age, they are getting injury due to accidents, है ना? And in the older age, they are getting injury due to some fall at home or fall outside the home.
Yes, sir.
Okay.
Yes, sir.
So the cause of injury is different for both, and the prognosis or the outcome of the treatment will be different because they have different cause of injury, number one. And the second, the age group is different because young patients will perform better definitely than the older patient. So does it affect the
But
study or not?
sir, but as they are both affected due to spinal cord injury, sitting balance will be affected in both equally.
Yeah.
But the sir is
So,
saying that recovery would be faster in the younger persons
Yeah.
because there would be a difference between the 18 years and the 60 years. Why there is a this much of difference is there, age difference?
sir, because availability of patient was also one of the criteria.
You
And
can
the
take the
evidence
small
is,
sample size, but your methodology should be clear,
Yeah.
na?
You can take the small sample size. So that will definitely have better results, na? More accuracy.
okay, sir, I'll look to that.
Okay, you can look into the
Yes,
matter.
sir,
For the more
I'll look
accuracy,
into
you
that.
can think about it. Okay,
Yes, sir,
you
okay.
can discuss with your guide and then you can plan further because your
Okay.
study is going on. That's a suggestion from the experts that you can include. Uh, Anything
Okay,
else,
sir.
Dr. Pawan, sir?
Definitely, I'll.
No,
Thank you, everybody. With this note, I would like to conclude our junior paper presentation category. Result would be declared in the valediction function. First, I would like to thank our guest, Dr. Pawan Sani sir, convener of the IAP Ghaziabad branch, and Dr. Snehal Patel, coordinator of the Maharashtra IAP Women's Cell. Thank you, Dr. Pawan and Dr. Snehal, for giving us your valuable time. I would like to thank our coordinator, Dr. Vaishali Chaudhary and Dr. Chitranshit Tomar. They are working throughout from last 3 weeks for finding it out which paper is judiciary or which paper we can take for the final round. Thank you, Dr. Vaishali Chaudhary, and thank you, Dr. Chitranshit Tomar.
Thank you, sir.
With this note, we end the session. Thank you all.
Thank you
Thank
all
you,
the
sir.
participants.
You, sir.
Thank you all the participants. Thanks.
Thank you, sir.